afternoon and thanks for joining us. I'm Judy Simpson. Today we feature another segment in our series of programs on cancer and your health. Our series is in partnership with Vermont Cancer Center, which allows you to hear directly from medical professionals who are experts in their field. In this program, our focus is on the #2 cancer killer in the United States. You may already know that lung cancer is the #1 killer and that breast cancer is #3. But the second leading cause of cancer deaths is colorectal cancer. Joining me are two experts from the University of Vermont College of Medicine. Dr. Neil Hyman is a member of the Vermont Cancer Center and a colon and rectal surgeon with Fletcher Allen Health. Also with me is Dr. James Vecchio. Dr. Vecchio is director of Fletcher Allen's Gastroenterology and Hepatology Unit. Thanks so much for being with us. Let's start off just taking a snapshot of what we're going to be talking about today as far as the anatomy goes. Dr. Vecchio, why don't you kind of walk us through that?
Sure, Judy. We're going to talk about the colon today, and the colon is called the large intestine as well, and there's many segments of the colon. On the right side is the ascending colon, hepatic flexure, transverse colon, left colon, and then the rectum. In medicine, what we try to do is try to create a whole bunch of, and you can see on the monitor now, different types of anatomy so we can describe where a lesion or a polyp is located. And again, when you look at the monitor, we look at it as if we're looking at the patient, so the right side is actually on the left side.
Okay. And so why the right side more so than the left side?
It seems that the colon cancer is moving. Used to be that the colon, the cancer was located in the rectum or lower part of the colon, and now it's moving slowly to the right side.
And you don't know why?
Don't know why.
And so how much area are we talking about? Like how long is the colon?
Right. Everybody's colon is different in length, but it's about 1 meter or 3 feet.
Really? That's a lot.
Yeah.
Is that a lot to sort of look at when you're...
Again, everybody's colon is different, and doing a colonoscopy or trying to look at the length of the colon through a colonoscope, sometimes there's loops and turns, and sometimes it's fairly straight.
And so in the introduction I mentioned the fact that colorectal cancer is the second leading cancer killer in the country. How common is it?
So generally, we would say that historically we say maybe 150,000, something in that range, of Americans get colon and rectal cancer every year. But, the really good news is that because of screening and improved treatment, every year for maybe the last 7 or 8 years, the incidence, meaning the number of people who've gotten cancer, has come down. And it's coming down significantly. And for the people who get cancer, owing to a variety, again, of improvements in screening and treatment, the prognosis is improving. So every year there are fewer cases and even fewer deaths. And
this affects both men and women?
It does, that's right.
And so why do you think there is such an aversion to the screening? Because if the screening is so successful, you'd think everybody would want to do it.
Right. I think it's important to understand there are different types of screening. People think that automatically screening means colonoscopy. Colonoscopy is one type of screening. And also colonoscopy has its sort of bad humors in a sense. The whole idea behind colonoscopy is to cleanse out the colon, get a good look, and see if there are any polyps, remove those polyps, and try to decrease the rate of colon cancer. I think one of the hardest things that people feel for colonoscopy is the prep. And one thing I'm going to mention over and over in this presentation is that the prep, the cleansing of the colon, is the most vital part of colonoscopy. If the colon isn't prepped, the colonoscopy can't be as ideal as it could be.
Plus, Judy, I might add that it's definitely not intuitive that somebody, Dr. Vecchio or myself, is going to put a scope in through the back passage, go 4, 5, 6 feet, and that's not going to hurt. But indeed, the colon has no sensation on the mucous membrane. Now, it can hurt going around certain turns, or different people's colon sensitive is not sensitive. But for example, when I turned 50, I had mine done without sedation. It's just not intuitive, that it would not be a painful procedure. But for most people, not everybody, it's actually pretty comfortable.
But there is sedation.
Right.
Yes.
Dr. Hyman is brave. When I had my colonoscopy, I had sedation. I would suggest sedation. I mean, I think that it makes it comfortable. Actually, the medications are remarkable, and sometimes I don't even remember 3/4 of what happened.
No, I just remember waking up and them saying, see you in 10 years.
Exactly right.
Yeah, and I'd like to add to that. So I certainly agree with sedation, because this is not one of life's experiences you need to lead to the fullest. People usually do not complain that I woke up and it was done. And often people say, when are we starting?
Right.
So I didn't mean to say that. I only meant to imply that it seems like it's got to be a gruesomely painful procedure, but it's not. I didn't mean to imply that I don't recommend sedation, because I do for the vast majority of patients.
You also brought a slide that shows how lethal colorectal cancer is in Vermont compared to death rates for other cancers, and I'd like to take a look at that just to sort of illustrate what we're talking about. I guess the top line there is lung cancer.
Yeah, this is an older slide though as well. I think again what Neil said is because of screening and different types of screening, the rates of colon cancer and colorectal cancer have been slowly decreasing. So this is, I think, is an older slide. And I think the more recent data are showing that those numbers are actually trending down.
And so what can I do to decrease the chances of colorectal cancer?
Yeah, I think that it's important that there are a lot of things that we can fix to try to decrease colorectal cancer rates. And one would be to try to have physical activity, try to avoid alcohol, quit smoking if you're smoking, try to avoid red meats, and try to increase the fiber in your diet. Those are the things that would be very helpful.
And again, screening.
And screening, some type of screening.
And so we're going to be talking more about the colonoscopy too, but what other types of screening are there?
Right. One is just a yearly checking to see if there's any blood in the stool, and that's called a fecal occult blood test. And that can be done at any doctor's office or any healthcare provider's office. Barium enema is a possibility where it's done with radiology, a flexible sigmoidoscopy, which is just looking at the left side of the colon. There's something called a virtual colonoscopy that's becoming a hit sort of with radiologists, and it's a CAT scan, but that requires radiation, and then colonoscopy.
Let's talk a little bit about screening. How useful is screening?
So that the whole concept with screening, when we talk about screening for a lot of cancers, most of the time we're saying, hey, let's detect it early, because we know that early detection leads to earlier stage diagnosis and much higher cure rates. And that's certainly true of colorectal cancer. But I think the central issue is that, in fact, we think we can do a lot better with colorectal cancer because there's no screening test that is perfect for colorectal cancer, but many, or if not most, of colorectal cancer start as colon polyps that over 5, 8, 10, 12, 15 years can evolve slowly into a cancer. So a primary focus and goal of screening is to find these polyps when you're younger, maybe in your 50s, and remove them so you don't get the cancer that polyp could have grown into over the next decade or so. So actually, it's been well shown that screening or colonoscopy prevents colon cancer by removing the precancerous polyps that would become cancer later in life.
Because that's done during the procedure, right?
Correct. Right. And it's important that anybody over 50 should be screened. We're good in Vermont. Excuse me. We've done well. About 70 to 71% of people that should be screened for colorectal cancer are being screened. Other parts of the country are less. And again, screening, colonoscopy is one type of screening.
Let's talk about the colonoscopy. What actually happens once your doctor says, okay, you need to make an appointment?
So what happens is that a data set, and it's important to make sure that you'll have a driver because you won't be able to drive after the procedure. Having received sedation, you're going to be feeling pretty good after the procedure and might not remember things, so it's probably not a good idea to drive. But again, the night before and the day of the procedure are vital. What we do now is something called a split colonoscopy prep. And that means that the patient will take 2 liters of the cleansing preparation the night before and 2 liters the day of the procedure. The data in the literature have shown that this is really good cleansing preparation. If people can remember anything, take the prep. A lot of people say, well, I can't possibly take 4 liters. 2 liters and 2 liters can be done. There are a lot of different ways of taking the prep, chilling it, putting different additives in it to make it taste a little bit better.
But it is what it is.
But it is what it is. Right. And it's supposed to be, and you're supposed to be near a bathroom. That's the whole idea.
Right. I mean, you really have to plan this out. And you have to, not be sort of intimidated or daunted when you get handed the jugs of
It's a liter. It's 4 liters. It's a gallon.
Yeah.
Right, that's fair. There's no pleasant way to have 37,869 bowel movements.
But, you got to kind of psych yourself up for it.
Right, and it's vital. If you're not prepped, don't go.
Because as a doctor, I mean, if you're doing the procedure on someone who hasn't prepped properly, it defeats the whole purpose.
Exactly. The better view, the best view, and some of the polyps on the right side, and people have been hearing about this for a lot of time, are called flat polyps. And sometimes if there's a little fluid or feces in that area and you can't see them, you can't remove them. If you can't see a polyp, you can't remove it.
And you don't want to have to go through this again anytime soon.
Correct.
So there's another slide that you brought along that shows us exactly what a polyp looks like, and maybe you can tell us what that's all about.
Sure. So as Dr. Vecchio pointed out, or implied, there's actually 2 kind of morphologies for the polyps. One is kind of like berry on a stalk, and those are the ones that more often occur on the left side. They're easier to find, easier to deal with, easier to remove. And that's why we're very effective at dramatically reducing the risk of cancer on the left part of the colon. On the other hand, on the right, not that you can't get those kind of polyps, but often there are very subtle, like little carpet-like polyps on the right side that are broad-based, ill-defined. They can be harder to actually see the borders, and that's where the prep comes in, because that's where it's really helpful. If you have a good prep, you know, we're far more likely to find those and be able to get rid of them. And then the other thing about polyps is not all polyps are the precancerous kind. And so to that end, there are other kinds of polyps that are not the kind we're looking for and of no consequence and don't mean that you have to be screened more frequently. So it's important to know what kind of polyp that you had.
Are the second kind of polyp that you talked about harder to remove? They're harder to see, but are they harder to remove as well?
They can be because they're flat, but we have different techniques to remove them. And all the polyps that we remove are sent to the pathologist and look under the microscope to define what type of polyp they are, so we can give a prediction of what's going to happen in the future.
And how long does this procedure take?
Everybody's different. I always quote between 30, 40 minutes. The whole idea is not to do the colonoscopy quickly. It's to be doing it effectively and visualize every aspect of the colon. So the slower, the better.
Okay. And we're talking about the colon, but what about intestines? Are they involved at all?
Well, intestines is a word for a lot of different things in medicine. There's small intestine and large intestine. We're talking mainly about the large intestine. Luckily, the small intestine is pretty quiet. It just does its job absorbing food and giving us nutrients. It doesn't usually turn into anything that's unfortunate. The colon has areas where the polyps occur and can have cancer.
Or said another way, that colon cancer is at least 50 times more common, you know, than a large intestine cancer. Colorectal cancer is far more common than small intestinal cancer, fortunately.
And so what happens if the polyps come back positive? What happens? Do you automatically operate, or?
Sorry, there are different types of polyps. Neil talked about benigns, when those are called hyperplastic. There are precancerous adenomas, and then there's cancer. If there's cancer, invasive, then the person would require an operation, and Dr. Hyman would be seeing that patient.
And then what would happen?
So, you know, first I agree with Dr. Vecchio that firstly, even some early cancerous changes in polyps, we can remove them colonoscopically and we don't need surgery. But for patients with truly invasive colon cancer, then surgery continues to be the mainstay of treatment. In other words, if Dr. Vecchio and I had prostate cancer, you could talk about, should we radiate, should we do seed, should we do surgery, but the only way really to cure colorectal cancer is with surgery. So typically it means you're going to remove the segment of the large intestine or colon that has the cancer and join the intestine back together. And then, you know, I don't want to drill down too deeply, but suffice to say that generally speaking, we remove lymph nodes as well. And if they have cancer cells in them, in those lymph nodes, then you might add chemotherapy. But surgery is the typical treatment, and in some cases might need chemotherapy, or in case of rectal cancer might need radiation as well.
And so the screening is recommended for people who are 50, turn 50. Do you think the people younger than that should consider it, or as physicians?
One group specifically that gets colorectal cancer a little bit earlier are African Americans, so they might need to be screened earlier. We have seen a trend towards younger people getting colorectal cancer, but the vast majority of people that develop colon cancer is after the age of 50, and that's why we've chosen the age of 50.
Yes, I might add two things. That's for average risk people, and that there are certain conditions like ulcerative colitis, for example, or also what's very important is the genetics and the family history.
I was just about to ask.
Yes, so that in other words, if you have a first-degree relative that your brother, your sister, your dad, your mom, you know, had colorectal cancer, then we would recommend that you start screening at age 40 or perhaps 10 years before the youngest age of somebody who had the colon cancer. And on the other hand, I think one big improvement in my mind's eye is also that we're not doing, in other words, that we typically stop at 75. That in other words, that I think there are a lot of unnecessary colonoscopies that can occur in the older age group. And so there are some people, because of certain genetic propensity, who should be screened beyond the age of 75. But generally speaking, colorectal cancer screening should stop at age 75 because the risk-benefit ratio is no longer favorable.
Right. There are risks to colonoscopy, and when you remove a polyp, there are risks. There are bleeding risks, making a hole in the bowel. There are risks to the medication. So we do it very well, but there are still possibilities of complications.
It's the bottom line, not to, do a bad pun, but people should see their doctors and really schedule this and have this as a routine because it can save their life.
Yep. They're over 50.
Thanks to both of you for joining us today. That's our program for today. I'm Judy Simpson. We'll see you again next time on Across the Fence.